This is our third panel, and this is addressing the sexual, urinary, and vaginal symptoms of menopause. And let me just tell you that this panel is freaking unbelievable. So you guys have the best, I mean, all our panels are unbelievable, but this is like the best of sex. Seriously. So
I agree with that.
I know you were going to say you're good at sex. So I'm going to introduce.
Say that, but
I'm going to introduce Dr. Lauren Stryker. She is the founding medical director of the Northwestern Medicine Center for Sexual Medicine. She has written lots of books that you probably want to get. One of them is Slip Sliding Away, Turning Back the Clock on Your Vagina, a gynecologist's guide to eliminating postmenopause dryness and pain. She also has a podcast and lots of other things in the works. So I'm going to let her take it away and introduce the rest of the panelists. Thank you so much, Lauren.
well, thank you so much. And thank you so much for saying that we're going to be the best panel, because now we're going to be the best panel, right? But we're going to start with a couple of quick survey questions. Super quick. Are we putting the survey questions up there? The first one is, has any doctor or any other medical professional ever in your life asked you about sex? And I don't mean about, do you need birth control? Okay? That question up there? Give you a second to do that one. And then the second question is, has any medical professional ever asked you about your ability to have an orgasm? All right, so let's see what the answers are. It's not coming up. Oh, wait. Oh, there it is. No, never have they asked about orgasm. And the other one talked about sex. That one's not coming up. Well, we'll assume that's the same. So none of this is any surprise to this panel. We know that. We know your doctors are not talking to you about that, and that's why we're going to go there. We're going to spend the next hour or so talking about vaginas, vulvas, orgasms, bladders, and specifically all of those parts that no longer have the benefit of estrogen. Now, before we get to the panel, I want to do just a quick definition. We threw out the word earlier, genitourinary syndrome of menopause. Genitourinary syndrome of menopause is also called GSM. I think we have a slide coming up on that. Jessica, do we have the, nope, back. Okay, so GSM, basically genitourinary syndrome of menopause. And this is a woman from the side. And we see the back side where it says back is there on the left, the front is the front. So what we now appreciate is that estrogen receptors are not just in the vagina. We have estrogen receptors in the vulva, which is on everything on the outside. Externally, a lot of women say that they're talking about their vagina. They're really talking about their vulva. The vagina is inside. And we have estrogen receptors in the bladder along the entire urinary tract. And when your estrogen tank is on empty, then we start to see profound changes in all of these structures. Next slide. So if you look, next slide. Next slide, Jessica. Is that working? Okay, outside. So if you look on the outside, which you should be doing, by the way, you are not imagining it if it looks like your labia are disappearing. They may be disappearing. And that nice rosy pink color, that means you've got a nice blood supply at the opening of your vagina and on the vulva, suddenly it gets very pale. And you might even start your urethra poking out a little bit. But then we go to the inside. Now, you can't see inside your vagina, but I can, and so can your gynecologist. And we don't have to talk to you. It's real obvious to us that we see that you have a loss of the structure. Those nice accordion-like folds that allow the vagina to expand, gone. Lubrication, gone. Elasticity, gone. So as a result of all of these changes, then you have the symptoms. So genitourinary syndrome of menopause is really two things. It's what are the physical changes that occur, and then what are the symptoms that you experience, both genital and urinary. It's not just about the vagina. So this is what we're going to talk about. We are going to go through these symptoms. We're going to talk about the fact that you have pain with sexual activity, not just intercourse, but any kind of sexual activity. Orgasm, like, forget it. It's just not happening, but this is all solvable. The itching, the burning. And then the urinary symptoms, the fact that you got that gotta go feeling all the time. You put the key in the door and there's no way you're going to get your pants down by the time you get to the bathroom before it's out. So recurrent urinary tract infections, all of this is part of GSM. So I'm now going to introduce this rock star panel because we are going to go there. We're going to talk about this. And you already know Cheryl Kingsburg, Dr. Kingsburg. But one thing you may not know about Dr. Kingsburg is that what she really wanted to be was not a psychologist. She wanted to be a comedian. So as a backup, she went into the psychology of, sex with lots of opportunity to be very funny. So we appreciate that. And then I'm going to skip over to Dr. Rachel Rubin, who is already a urologist, sexual medicine urologist, who is very famous, but became more famous last month when the New York Times did an article on the clitoris. So now we have crowned her the queen of clitoris. And she even has a lovely clitoris necklace, which maybe she'll show you, which I covet. And then our third panelist is Dr. Maria Ucoco, who is also did I just say that wrong? Uvocos. I'm sorry.
Loco, like you're crazy in Spanish.
Exactly. I'm sorry. And I love this panel already. And also a urologist, sexual medicine expert, who the fun fact I learned is that you are in the top 0.01% listeners of Beyonce on Spotify.
I am. That 3 years in a row.
And there you have it. So, but okay, what we're going to do to start this off is we're going to start with Dr. Kingsburg, because we are going to be talking a lot about these physical changes, but we can't ignore that there's a psychological component as well. So can you just start by talking about how that all interacts?
Sure. Well, treatment number one, changing your position. So here I have changed my position. When we think about sexual response and sexual function, healthy and dysfunctional, you really, and we talked about it before, but in sex in particular, you need to think about it from a biopsychosocial perspective. There are many things in physical health that will contribute to sexual dysfunction. So your general physical health, whether you have diabetes, whether you're overweight, whether you have thyroid problems. Also, neurotransmitter dysfunction will impact your sexual function, and certainly hormones will affect sexual function. But beyond that, you have psychological factors. Depression, we talked about that before. There is a bidirectionality between depression and sexual function, particularly desire, or anxiety. Think about performance anxiety. Males, people with penises, tend to worry about getting and keeping erections. Females worry about reaching orgasm, which Dr. Stryker will talk about. So the more you worry, am I going to get there? Am I going to reach an orgasm? You're done, because now you're distracted. Sociocultural factors, religious, prohibitive cultural backgrounds that say sex is dirty, girls aren't, or women aren't supposed to be sexual, absolutely tremendously negates sexual function in women. And finally, the interpersonal component is huge. The quality of the relationship, if she has one that somebody is in, will make a difference in her sexual function. You could have all the biologic drive in the world, but if you don't like your partner, you're not going to want to sleep with them. And so you need to think about that when you are approaching your clinician or thinking, what's the matter with my sexual function? Sometimes it's 1, 2, 3, or all 4.
So, Dr. Rubin, I'm going to throw this over to you now, because we're going to be circling back to this a lot as we go forward. But I would like you to just explain the nitty-gritty of why does penetrative sex hurt, whether it's a penis or a toy, but why does it start to hurt in a woman who is whose estrogen tank is on empty?
Okay, so this is, do y'all hear me? Apparently I've had major mic malfunctions. No, you can't hear me?
Hold it the way I...
All right, sorry guys. Now do you hear me? All right, major mic malfunctions. Similar to sexual dysfunction, right? When things don't work when you want them to, and no matter how much breathing and yoga you do, if the machinery is not working, it's not going to work. So this is really important, right? Biology is really important when we're talking about sexual health. And I love that Dr. Kingsburg is here. Look at this incredible panel. You've got a gynecologist, 2 urologists, and a clinical psychologist who, this is all important for sex. It's not one or the other. It's a team approach. And the physical therapist in the room, hello, we love you. So biology is really important here. And so who has ever, this is a weird analogy, but I'm going to do it anyway. Who here has ever changed the diaper of a baby girl? You can come to my house if you want to. So it's really important. Babies, okay, do not have hormones in their bodies. They have teeny tiny vulvas. They have no labia minora. They pee their diapers all the time, right? And they're constantly saying, "Ooh, mom, it itches. Mom, I don't, it doesn't feel good." We put diaper cream all over it because it looks painful to us, right? That's why diaper cream was invented. So we didn't have to look at how, uncomfortable it looks. That is no hormones. Then puberty happens. The teenagers, they start getting mean to you and they start getting sassy. Who has teenagers, right? Yeah, I'm sorry. But their bodies change and transform. They grow labia minora. The tampons can start to go in, the menstrual cups, which all the teens love, right? They start to go in. So the body literally morphs and changes. And it's not just an estrogen story, but it's a testosterone story too, which we're going to talk about. And so what happens in perimenopause and menopause is now all those receptors, which were so full of hormones and getting all the hormones, like getting a plant, getting enough water, right? So full and blossomed, now start to lose all of that water, right? And you no longer have it. So it could happen before you stop getting periods. It can happen later, but over time, without hormones, the bladder is affected, the urethra, the vagina, the vulva, the clitoris, all of the parts, right, are affected. So it is not just hot flashes and night sweats. And without hormones, it's not just vaginal dryness either. It's urinary frequency and urgency, just like Dr. Stryker just said. And so sex can become painful. Orgasm can become muted. It can take longer. The things that worked 30 years ago ain't working anymore. And it's really hard to say to your partner, "Honey, a little to the left." Who has a hard time saying, did you learn how to say that in middle school? I didn't, right? And how do you have that conversation? So this is really important because we minimize the term vaginal dryness. By telling women it's just a little vaginal dryness, put some lube on it, we're actually killing women because women are dying of urinary tract infections. They're getting divorced. They're having a difficulty communicating with their partners. This is a huge problem that we're really not capturing by just saying, "Oh, it's a little vaginal dryness."
And okay, when does this happen though? Because everyone thinks that this is going to happen the same time as the hot flashes. So Dr. Loco, talk about when does this vaginal dryness and this painful sex hit?
So the vaginal dryness and the painful sex can hit at any point in time, actually. So, because all of this is related to hormones. So anything that's going to essentially affect your hormone status can essentially affect the health of your vulva. So I always tell people that this is such an awful analogy and I apologize, but your vulva is a garden. And so without hormones, you cannot water that garden. And my patients groan and but it actually makes sense. So if you don't have the appropriate hormones, and it's more than estrogen, it's also testosterone, there's progesterone as well, to keep that garden healthy, that's when this is going to happen. So perimenopause, some medications can also cause this. Anything that essentially affects your hormone status can affect your vulva, which then, if you don't have a healthy vulva, you cannot have a healthy bladder, and you cannot also have a healthy pelvic floor.
But I think also, go ahead. Okay, go.
Here's the problem with midlife is that hot flashes and night sweats, every single woman knows is about menopause, but they don't know that GSM is related to menopause. And what tends to happen is that it occurs a little bit later on. And so they're like, "Oh, I'm done with menopause," but yet they're having these symptoms that they don't know are related to menopause. So they're not bringing it up to their menopause practitioner or their primary care. They think it's just a natural part of aging and I'm supposed to learn to suffer and live with it, when you guys absolutely can treat it. So it happens usually a little bit later on. And while night sweats and hot flashes sometimes will eventually go away, GSM is chronic and progressive and will only get worse, may even kill you, but will only get worse with time if you don't treat it.
If it's not treated. When you're done with menopause, when you die. There's no such thing as "I'm done with menopause." You will never have the benefit of estrogen again without treatment until you die. And that's the reality. And it's so important because a lot of people think it's a normal part of aging. So let's talk about, we're very solution oriented here. So Dr. Loco, start off by just quickly reviewing through the over-the-counter treatments, because we know you are not going to your doctor because they're clueless. We've already established that. So you are going to go and find what you can to grease the skids. So what's out there?
Yeah, so the over-the-counter options are essentially, we're not getting down to the root issue, but if for some people, it's a great option for them. So things like topical moisturizers, lubricants are also a great option for people. Things like coconut oil, olive oil, things that are essentially not caustic to the skin, but can provide the lubrication and help mitigate the symptoms of the vaginal dryness. So that's typically where people will start with over-the-counter.
Do we all agree that coconut oil and olive oil are good lubricants?
Yes, you have to be careful with condoms, though.
Not
Yes.
condom compatible. They can cause infections, and I quite frankly don't think they're slippery enough. And I don't really think people want to smell and taste like an olive oil. I'm just kind of throwing that out there.
We differentiate lubricants,
Lubricants
from
and moisturizer,
moisturizer.
they're not the same thing. That was my next question. Go
So
for it.
first of all, lubricants are a multi-million-dollar industry for a good reason, because millions of women use them. So please don't feel like there's something wrong with you. And tons of premenopausal women are using lubricants. For a postmenopausal woman, tough word, osmolality, you really need to look at what's the ingredients in your lubricant to make sure it's not drying, right? And so that's important. So a lubricant you use during sexual activity, it is short acting. You can use a water-based, please water-based, or a silicone-based. Think about what the ingredients are if you're sensitive. A moisturizer is just like you would use for your face or your legs for dry skin. It will help provide moisture. It will not treat the underlying condition, which you talked about. That will not treat that, but it will help with moisturizing. Use that 2 or 3 times a week, not during sex. Lubricants during sex, moisturizers, just as you would moisturize your skin.
Okay, so once you have decided that that's not going to do it for you, you might have to actually bite the bullet and go to your doctor, but we want you to go and ask for a prescription because your doctor may not know what to give you. So, Dr. Loco, why don't you now walk us through what are the categories of prescription options? We won't get into too many details about them right now, but just kind of run through what the options are for, because one of the things I want to make the point that lubricants do not change the tissue. They only make it more slippery. And that's why they're not going to work for everybody. A prescription is going to change the tissue. So what are the prescription options?
Yeah, so prescription options, essentially you can break it down into prescription options that is going to restore estrogen back to the tissues. And there are various options. You can do a cream, you can do a gel, you can do a tablet. Then there's also the option of estrogen and testosterone. There is an FDA approved option, and that's typically FDA approved for patients with not only sexual dryness, but also sexual pain. So that is a medication called prosterone. It's a vaginal insert as well. And then there's also selective estrogen receptor modulators. So these are oral medications for people that it's not safe for them, or it's been deemed not safe for them to have a direct estrogen. So that's another option for patients.
Yeah, and just to clarify, the progesterone that you were talking about, that's actually not estrogen and testosterone, it's DHEA, which is the precursor, and then your own vaginal cells make estrogen and testosterone. And as we talked about before, testosterone is not a male hormone, it's a human hormone, and it's very important in the vagina. So Dr. Rubin, so now the woman has gotten her prescription, she's brought it home, and she's read that terrifying label. Can you talk about that, please?
It's so important, right? So not a day goes by where a patient doesn't come back and say, well, I've been given this prescription 3 times, but I'm not going to use it. It says that if I use this, it's going to cause stroke, heart attack, blood clots, dementia. And if I don't use this product with progesterone, it's going to give me endometrial cancer and I'm going to die. Dr. Rubin, you are trying to kill me. Every day, right? So this is actually a big problem. And for any of you listening who work at the FDA, we got to talk, right? We got to talk because this labeling, the box labeling is killing people, right? Women are not using these products because they are afraid. And there is not one documented case really of vaginal estrogen or vaginal hormones doing any of those things. No data. Come at me with the data, people. Show me the papers. They are not there, right? And so here's the problem. The Women's Health Initiative, which was so beautifully explained by that brilliant Yale doctor, it was incredible, that first panel, right? It really screwed a lot of things up. So even the labeling's not even based on the actual data that the WHI came out with. It says with you, right? So that the FDA labeling is for all hormone products, but not all hormones are the same. Estrogen is not the same as progesterone, which is not the same as progestin, which is not the same as testosterone. An oral birth control pill is not the same as a patch, which is not. So we have to understand there's a lot of gray here. So vaginal hormones, local hormones that are treating GSM, genitourinary syndrome of menopause, are pretty much safe for everybody. Again, you heard it earlier. The only patient where I will pick up the phone and have a conversation with an oncologist is if they're on an aromatase inhibitor, and I'm still going to push for it because this is not a little vaginal dryness. This is recurrent urinary tract infections, which can kill my patients, right? And so it's very infuriating as a urologist because we see the changes, we see the pain, the sexual dysfunction, the urinary frequency, urgency, leakage, these really significant symptoms. So we have to educate, and I do a lot of teaching and yelling. Dr. Luca and I do a lot of screaming and yelling about how the box we must educate patients before they leave our office of this box is based on if you took a different pill completely by mouth, and even that's probably much safer than what this box says. So we have to tell them that the labeling is wrong, and we get on our soapboxes and we talk politics and we talk the FDA. I'm in DC, so we talk politics all day, and we get them to understand that this is wrong, right? It would be like a condom label saying condoms cause blood clots. Right? Because birth control pills can cause blood clots, and it's both contraception, so condom labels should say cause blood clots. Well, that's ridiculous, similar to how ridiculous it is that vaginal hormones have that labeling. So for anyone
don't
who
read
has
the label, and just to put a button on this conversation,
please.
We have 4 experts on the stage. Raise your
short.
hand
I'm
if you give a local vaginal estrogen to a patient with breast cancer.
Oh, all day.
And there you have it.
But can I put this in context? Vaginal estrogens, when you think about, Dr. Minkin said you might get a little teeny bit of systemic absorption. The amount of systemic absorption of 1 year's use of a vaginal estrogen is the equivalent to about 2 birth control pills, right? So total.
Maximum.
1
For the
year,
whole year.
Maximum.
1 year, 2 pills.
And not to mention, women who carry extra weight make estrogen in their fat, and they carry more estrogen on them than they could possibly put in their vagina. So
just again, numbers I think are super helpful here, right? When you're in menopause, your estrogen levels are 0. When you're on vaginal hormone products, guess what your estrogen levels are? 0. It stays 0. When we give a woman estrogen, like systemic estrogen, we're looking for your estrogen between like 25 and maybe 60. A man's estrogen is 25. Right? A man's estrogen is 25. When I was pregnant, my estrogen was probably 3,000, right? And so we're not running around to pregnant people saying, oh, we got to get this baby out because you're going to get breast cancer, right? Like this doesn't happen. Do women get breast cancer? Of course, it's horrible, right? But the idea that your estrogen level that stays 0 with vaginal hormones, what are we afraid? Like, what is the fear? Like, that's my problem. There's nothing to fear.
okay, we have to move on from painful sex, otherwise we'll never get to orgasm, and I know you all want to come to org. So, but one last thing, I want to make the point, and the panel wants to make the point that you should never have sex. 0 sex is acceptable, and there are cases in which you are having an adequate estrogen, you're using your estrogen, you're doing everything right, you've got your lubricant, and you're still having pain. And so, one of you please jump in and talk about the role of the pelvic floor, the pelvic floor muscles, where they come in with all this.
Okay, so pelvic floor physical therapists are angels on earth. And I will go to my grave saying that. So I'm an athlete, and when I think about the body, I think about like how can we physiologically make our body better, and so hormones play a big role in that. And if we think about the pelvic floor, it's literally a girdle. Like it's a girdle made of muscle. And so if we again, this is where biopsychosocial comes into play. If you're someone that has had painful sex, there comes the secondary fear that happens of guarding. So I always use the analogy of if I'm going to throw a punch at you, what is the first thing you're going to do? You're going to want to, tense up and block it. And that's what happens essentially with penetrative sex. If you're having continuous pain with penetrative sex, your pelvic floor muscles are oftentimes going to tense up without you knowing, and that's actually the terminology of vaginismus. Everyone talks about vaginismus, but it's actually the tensing up of the muscles, that psychological connection between those two.
That is the anxiety
Yep,
response
exactly.
to the experience or anticipation of pain.
And so I think if we just kind of think about just how the American culture, and we're a very sedentary culture, you know, everyone needs a pelvic physical floor therapist, no matter what. If you have a pelvis, you should have a pelvic floor physical therapist, because we really don't know. There's a lot of mind-body disconnection. And so just in general, at baseline, I think everyone needs a pelvic floor physical therapist. But then now you have dysfunction on top of that. And so those are people that are going to help reset the muscle. So we can help treat your tissues. Dr. Kingsford can help with the psychological component, but we need someone to help with the muscular component. And that resetting the psychological muscle response of, okay, I'm going to have penetrative sex. I'm going to relax. I'm going to breathe. I'm going to strengthen my core. I'm going to use that breathing exercises, the strengthening core exercises, the flexibility, all of these things. It's a really amazing tool that we have, and we are so thankful for our pelvic floor physical therapist.
It's really important for everyone to know this is not just a Kegel exercise. In fact, a lot of times you want to do the reverse thing of Kegel exercises. How can I strengthen so I don't leak? So don't, and by the way, research shows that if everyone do a Kegel exercise right now, 80% of you suck at it, right? So excuse my language, but right, like no one taught you. So actually having a coach teach you you're all using your butt muscles and you're squeezing all these things. So you're doing it wrong. And so what a physical therapist does is customizes the treatment for you of like, wait a minute, this muscle's too tight. This muscle's too weak. This muscle's too strong. Like, how can we actually get your body functioning? And the idea that you can just, do it yourself or read a Google, article about it and all of a sudden you know what you're doing, hire a coach. That's where it becomes extremely helpful. And there are a lot of amazing websites that you can find a pelvic floor physical therapist on. The American Physical Therapy Association has a great website, and again, you can't just see anyone, right? You can't see a knee guy who's going to help you with your pelvic floor. You have to see, just like menopause and sexual medicine, you have to see a specialist or someone who has said, I care about this and this is what I do.
All right, so we've established pelvic floor PT are magicians. We have to move on.
No, you
Okay.
have to give a
Just so you know, we're all
moment.
friends.
You have to give a moment to cognitive behavior therapy. Somebody asked what it is. So for vaginismus, that is, you could treat all the pelvic floor muscles and you can give vaginal estrogens, but once that anticipation of pain is there, and women need to know that, it will not work until you have done some cognitive behavior therapy, gradual exposure, teaching your body you can be trusted again, because it lost trust in you and the vagina takes over and says she's not so bright. She keeps trying to put something in that's going to hurt. So we will protect her from herself and tighten up and prevent. And so there is cognitive behavior therapy to gradually expose to allow for wanted penetration, whether that's a tampon when you're a kid or a pelvic exam or penetration for sexual activity. Okay, now you.
Thank you. Okay. Don't panic when the penis enters the room is what you have to tell your vagina,
If
right?
it's a penis.
The penis, whatever.
Let's not
Okay.
say-
So let's move on to low arousal and desire. And I'm going to let you have the floor again, even though I'm concerned that, it'll keep going. No, I'm kidding.
Okay.
All right. So Dr. Kingsburg, let's talk about the two kinds of issues that are going to impact desire.
Okay. So when we think about sexual problems for women, think about it as 4 categories. Problems with desire, which is wanting to be sexual. That is wanting the anticipation, sort of your appetite. There is arousal, which is the body's ability to feel sexual pleasure, genital arousal, which you need hormones for. So lubrication, blood flow to the urogenital tract. Then there's orgasm, which you're going to talk about. I won't. And I'll leave you waiting for that. And then pain with sexual activity. So desire is the wanting and arousal is the genital response. It isn't always in this linear progression. So for many women, they will have what we call spontaneous desire. How often, and I won't ask, but how often does your body signal that it feels a little horny, that you would have a thought about sex, whether or not you act on it? That is your biologic drive. But many women will have what we call responsive desire. They don't really have as much biologic drive as they may even want. But once they get started, then it triggers a response. Then they're like, oh yeah, sex. This feels great. Why don't we do this more often? That's a wanted response, which, by the way, happens much more often in long-term relationships. You know, we always challenge, is it the age of the person or is it the age of the relationship? It is the age of the relationship that tends to cause that kind of boredom and lack of interest because, you know, that lover that you couldn't wait to see when you were in a new relationship is now the person you've lived with for 20 years, and that's, you know, a little boring. So it's validating to know there's nothing wrong with your relationship. You need to spice that up and put a little bit of romance and passion in. And so that would be more the responsive desire. We were talking about exercise before.
Yeah.
So the analogy I use with women is how I feel about exercise to the athlete sitting next to me. I have no biologic urge to work out. None whatsoever. If I waited for my own drive to work out, I would never work out a day in my life. So I don't rely on that. I know better. I show up at the gym, I put my workout clothes on, I get on the treadmill, and only when my heart rate's up, I've worked up a little sweat, then the smile will come on and I'll say, oh, this feels great. Why was I so hesitant? I'm going to come to the gym tomorrow. And then tomorrow will come and So for many women, it is validating to know if once they're there, they can enjoy it, that may not be a sexual problem. But for many women who used to want and now have lost that, what I will say is women want to want. That is the problem with desire. They've lost that wanting to want. And that is spontaneous desire versus responsive. Did I take too long?
No, there was not. But I think you made such an important point about the SSRIs because so many women are more likely to take an SSRI than a man, particularly midlife, because they're depressed and they're anxious. And instead of their doctor treating their menopause, they put them on an antidepressant, which then kills their libido, which is the #1 sexual complaint. So, Dr. Loco, could you talk about a strategy for a woman who's taking an SSRI and has found that she's lost her libido? What options does that woman have?
Yeah, so they have several options. So one option is seeing if they can switch SSRIs. There are actually medications in their newer SSRIs that have less sexual side effects. So just informing the patient is always really the biggest thing. Informing and validating people is like 50% of the job. And then just making them understand that like, this is a normal part. There's so much stress when people come to my office of I'm abnormal or there's something wrong with me. And I'm like, well, in theory, this is an issue, but there's nothing wrong with you. And these are the reasons why it isn't. And so just again, validating and then letting them know that there are different treatment options that are different SSRIs that are better options that don't necessarily have as much sexual side effects. And then cognitive behavioral therapy, that's a biopsychosocial model, really. Like you cannot treat sexual health by just one. There's no one cure fix. And so also talking to them about that. And then what other options, what do you think of, Dr. Rubin?
I agree with everything. And then the idea that there are biological things to help boost sexual function. So if antidepressants can cause sexual side effects, and anyone who's ever taken an antidepressant knows that there are sexual side effects, including low libido and delayed orgasm, right? And so if there's a medicine that can hurt your sexual health, could there be a medicine that could boost your sexual function? It makes perfect sense. And we have options, right? So again, it's often synergy, right? If it's a crappy relationship, there's no pill that's going to make it better. But it's all, I see that woman who comes in who says, geez, Dr. Rubin, I love my partner. My life is like pretty good. I'm really happy. I just want, right? I'm on this stable dose of an antidepressant. I'm not depressed, but I want. And so that woman has both hormonal and non-hormonal options that she can choose from of what she wants to maybe try. Has about a 60% chance of working for her.
Could you please just say there are two FDA-approved options for premenopause women. So talk about those two first.
Okay, so testosterone, which we talked about earlier, right? It's not an FDA-approved option for women, but it is in Australia. Okay, so we know that there's a lot of evidence behind testosterone and low libido. And we have 2 FDA-approved options that are approved for low libido, but not in postmenopausal women. They both work great in postmenopausal women because a 49-year-old's brain and a 53-year-old's brain, not that different, people, right? And so if you can boost dopamine in a woman's brain, you can improve libido. Doctors have been using bupropion and Buspar, Wellbutrin, for years for this reason. So the 2 FDA-approved options, one is called Addy, okay? It is a pill you take every night at bedtime. Takes about 2 to 3 months to boost dopamine in your brain, but has about a 60% chance of improving your libido, arousal, orgasm, and satisfaction. So it's not just a libido drug, it's a sex drug. And it works. It actually helps with sleep issues surrounding perimenopause and menopause. And the other one is called Vyleesi, which is an auto-injector that you use about an hour before you want to want. So some people take a hit of dopamine in the form of a glass of wine. Some people take a hit of dopamine in the form of vacation sex. Other people take FDA-approved hits of dopamine. And so again, there are, these medicines actually have been studied in randomized placebo-controlled large trials. And when you do a sex trial, by the way, if you want to get into sex research, it's actually quite challenging because if I give you a sugar pill and tell you it's a sex pill, guess what? You have great sex. Right? Like the placebo response is very strong. And so these are options. That Addy pill is approved in Canada for postmenopausal women. So I always tell my patients, if it's good enough for Justin Trudeau's people, it's good enough for you. And again, you can have access to these medications. They're just not often very well covered by insurance because if you know, insurance is going to do anything they can to deny you any kind of medication, even for blood pressure, let alone for your sex drugs, right? It's the reality.
Yeah. But I just also want to throw in there, you have to get rid of the pain first. If you have any pain, forget treating libido. So, Dr. Loco, we mentioned testosterone. Could you briefly talk about the use of testosterone off-label in postmenopause women specifically to boost libido?
Yes. So I love testosterone. I am also a researcher, and I think there's just so much in sexual health, so testosterone, let's talk about it. So everyone, when I talk to them about testosterone, they're always like, oh my God, but that's a male hormone. And so I say, hormones, like we've talked about, are not binary. Everyone produces hormones. And actually, if we actually quantified how much testosterone is versus estrogen, you're making about 1,000 times more testosterone than you are estrogen. Testosterone's in micrograms per deciliter, and then estrogen picograms, and that's just an order of magnitude. Testosterone are making way more of it. And then if we actually, yes, some of that is then converted into estrogen, but this is where the research, I do a lot of research because of advocacy. Research is advocacy in my mind. There's still so much question regarding what the role of testosterone is because no one has looked at that, really spent a lot of time looking at that because we've always just been like estrogen is for women, testosterone is for men. But I digress. So when we actually think about where we are in testosterone and what we know so far is that testosterone, there is no FDA approved option for it, but there are several guidelines regarding testosterone use in postmenopausal women for the indication of low libido. So typically what we would recommend doing is a transdermal option. So let's talk about capitalism and hormone and in the space of menopause. So because there is there's no set clinical guidelines for each practitioner. We're not learning these things in medical school. There are set guidelines nationally, but we are not learning these guidelines in medical school. So then patients aren't getting at their care versus these direct-to-consumer people are able to then go directly to the patients. And then give them good information or bad information. And so I think there's a lot of information regarding BioT and pellets and all of these things. And I'm a big believer that testosterone is a very vital hormone, but there is at this point in time no evidence on how these pellets, these BioTs, all of these other options that aren't transdermal are safe and effective for patients. And so that's why we always kind of caution, we caution it at this point in time. But as a researcher, I do love that we are pushing the envelope in terms of research and asking these questions. And that is where we're going to see. But for right now, now, what we do know is that transdermal options for postmenopausal women or postmenopausal people with low libido is a great option. And the hard part, again, is access and finding people that feel comfortable.
And I think all of us are comfortable prescribing. I know we're all comfortable with testosterone, but I do want to mention again with the pellets, extreme caution that it is associated with an increased risk of uterine cancer and other complications. So just be careful out there.
Yeah.
And Dr. Kingsberg, I want you to talk a little bit about, the first panel talked a lot about hormone therapy, of course, but they didn't really talk about the impact of hormone therapy on libido. So could you address that?
Well, estrogen and progestin will certainly help with vaginal symptoms, although systemic hormones are not always enough, by the way. So please pay attention. If you still have genital symptoms, even though you're on systemic hormones, that's why urogenital. I did not say
We
that.
do have 2 urologists up here, Dr. Kingsberg. We have to be in the
So urogenital
never forget the
symptoms,
bladder.
Please don't think that that's all in your head. You probably need to be on local hormone therapy as well. So that's number one. It will not typically help with drive, with sexual interest, except for taking away pain. It is testosterone.
And letting you sleep, which
Yes,
also helps.
Absolutely. That is very true. So if you're not sleeping well, your sexual desire is probably going to be low. So thank you for that. But testosterone is the one hormone that has been shown to be effective for treating low sexual desire. And, you talk about the politics of this. Those of you who remember Procter & Gamble had a testosterone patch that was trying to get approved in the US, but it got completely decimated in an advisory commission when they wanted a women's health initiative level safety trial for testosterone in women because they were so afraid.
Right. They didn't find anything bad. They just wanted
they wanted
more and more. And
so
more.
it did not. It got approved in the UK for surgically postmenopausal women, and it has never come back. Nobody
And it
has
never
been able
will.
to get it approved.
If people want to get up in arms, so as a urologist, Dr. Rubin and I treat all genders, and so looking at that research of they wanted more safety, they wanted more. I am currently enrolled in a clinical trial. What we know about testosterone in men is it's contraindicated or not. We don't want to give it to men that have had a known heart attack because we're concerned that it could potentially cause more heart disease. But there is this is why it's so fascinating to be on the precipice of all genders. We take care of all genders and see completely the differences in care and the access to care. I am currently in a clinical trial where we are giving men with known heart attacks testosterone. You could never do the same trial with women and estrogen. There's always so many more barriers, always so many more to getting them the care and the access and the degree of quality of life versus, oftentimes I have to tie a lot of my grants, a lot of the stuff that I do to my male patients and saying I'm currently one for female sexual dysfunction and men with erectile dysfunction. And that's how I get my money. That's how I get my funding. That's how I get things pushed forward. But that's a little ridiculous. And so really always kind of questioning why am I having a hard time? So politics, advocacy, research matters.
Research matters, which brings me to the next topic, which is cannabis. How many of you out there have just thought, okay, little cannabis to help with the libido, to help with all this stuff? So roughly 1 out of 4 postmenopause women are using cannabis for relief of one, if not more than one, menopause symptoms. And this is something that I'm studying. We have zero data when it comes to cannabis and libido. And in fact, any publications out there about libido and cannabis are in 20-year-olds who have no problem with their libido, but they say it makes it better. So there's not a lot to say about it other than we know it's being used. You do have to be careful postmenopausally. Postmenopause women do metabolize cannabis differently, and that's another topic for another day. But I know you're out there using it, and you're quite frankly better off going with some of the things that are more studied and we know something about. All right, I'm watching the time. We're going to talk about orgasm a little bit. Let me just say that the reason why, there's a very specific biologic reason why postmenopause women have such difficulty having an orgasm. And it is simply that you need to have intact, sensitive neurons in the clitoris in order to have an orgasm. And between a lack of hormones, aging, smoking, and in many cases, medical illnesses such as diabetes or vascular disease, those nerve endings just become dead. So you are not imagining it. It's blood flow, and it's not keeping those nerve endings healthy. That's why it is so difficult to reach orgasm, or impossible for some women to reach orgasm postmenopausally. So, so what do we do about that?
All right, so Dr. Luco and I both treat men, and we treat erectile dysfunction. 50% of men who are 50 have erectile dysfunction, 60% of 60-year-olds. The penis needs three things to be healthy: healthy muscles, healthy nerves, and healthy arteries. The clitoris and the penis are exactly the same thing. They are exactly the same thing, made up of the same smooth muscle tissues, the same nerve endings, the same erectile tissues, and they work exactly the same way. It's just that the clitoris is all inside the body, right? In fact, you're all sitting, if you have a clitoris, you're sitting on it right now, your butt bones, it goes all the way down to your butt bones. If you have a penis, you are also sitting on your penis. All of you on your Peloton seats, you're crushing your genitals, right? I have one too, but you're sitting on your penis, you're sitting on your clitoris. So you need three things: healthy muscles, healthy nerves, and healthy arteries. And so the reason why vibration works so well for all genitals, by the way, everybody should be getting devices, and sex tech is incredible now compared to many years ago, right? Where you had the newspapers on the windows and you had to like create, you can go on Amazon and get a very high-end device. But the reason is the clitoris is mostly internal. And so how can you activate that erectile tissue is often through some kind of a vibration. So again, hormones, muscles, and nerves. You could take hormones, and the clitoris responds very much to testosterone, and certainly estrogen, we know, can help with vaginal hormones. Vaginal estrogen can help with orgasm. Devices, good cardiovascular, right? Exercise is helpful. Viagra and Cialis works for penises. It works for clitorises too. It's just that it is not, it's been studied. It works fine to increase the erectile function of the clitoris, but most women are bothered by their desire, the dopamine in the brain. And so you have to treat synergistically. I rarely just give a woman a Viagra prescription, though I do give the prescription out, but it's often in kind of like, in conjunction with other therapies that we're doing. Yeah. And I got to give a plug for sex therapy. Like, nobody can't get better at sex, y'all. We can all get better at sex, right? You just got to work at it a little bit. And communication, y'all are so successful in your jobs because you meet about it, you talk about it, you plan for it. Like, why wouldn't you invest in getting better at sex? It sounds like it's not that hard. It's not that difficult.
Okay, well, this is all well and good, but let's just start by saying that you need to start with the vibrator. And no, but there's a reason why. There's a biologic reason why, and this is it. I talked about healthy nerve endings. There's lots of different kinds of nerve endings. There's thick nerves, there's skinny little nerves. All the nerves in the clitoris are really, really small. It turns out that the nerve types that respond to vibration are the largest nerves in the clitoris. They're the last to go, women. They're the last to go. So if licking, touching, stroking isn't working for you anymore, vibration will. A vibrator is not a sex toy. It is a sex tool. It is a sex tool. So you start with vibration first. And Dr. Kingsburg is going to tell us what kind of vibrator to buy. And she's also going to tell us how, when you want to bring Bob, that's your battery-operated boyfriend, into the bedroom, how you're going to explain that to the person who's already in bed with you.
So that goes back to sex therapy, and you don't need to spend a fortune. So let me just say, it's accessible to all. Thank you to Amazon and goodvibes.com. There are many websites where you're not going to end up with all that spam email. There are sort of female-friendly places. But really, don't spend a fortune, but you have to think about what kind of sensation works for you. Some women really want something that is going to sort of blow on their clitoris directly. Others do not do well with direct clitoral stimulation. So you need a much more sort of diffuse kind of vibration. Some people are going to like something with a rheostat that you can control it's not just vibration, it's what's the intensity and the speed of the vibration. And so you got to learn to see what works for you. And that's why you don't want to invest in a really expensive one at first. Go inexpensive, find what kind of vibration works for you. And then you need to explain to your partner, if you have a partner, that this is important for enhancing sexual health. You know, your partners want to feel desirable and desired. And so if they see you as bored and unsatisfied, they're not happy with that. So if there is something that they can do and be a part of, that they can feel like, wow, look at her response, they're very happy, especially when you say it really isn't you. This is me. And they're willing, yes. And men, you know, people with penises get it that, you know, you said at 50, they're not getting instant erections at the mere sight of their lover anymore. And the partner needs to recognize it's not that they're not attractive anymore, it's that the penis doesn't work that way. I'm talking to two urologists over here, but I hope you can back me up on that.
Yeah, that's right. That works. I also like to say that sex is play, right? And so kind of coming at it from a kind of from a playful mindset of, well, let's see, and kind of curious of like, what does this setting feel like? What does this vibration setting feel like? And, you know, it's literally called a sex toy. Like, have fun with it, and incorporate that into sex, and figuring out and having the communication piece with your partner of like, let's go have fun with this fun new toy.
Fun as a doctor, right? Doctors and all clinicians really should be talking to their patients and giving their patients permission to play with these devices and discover these devices, because I actually find biology really helps here. When I'm teaching my male patients about how their penises work, I'm also teaching them how the clitoris works and where it is and why they didn't learn it in middle school either. And again, as urologists, it's really fun because we can take care of any love triangle that comes into our office, right? And so it doesn't matter who you're trying to have, like literally come to my office, let's talk about what genitals you have, what genitals you want, and how you want them to work. So it's not really binary, and it's not really male or female or even heterosexual for that matter. It's let's talk about what is the biology here and how is it functioning? How is it driving? And do we want it to drive better? And there's nothing wrong with wanting to have more fun, more quality of life. It doesn't have to just be about hot flashes. And I think maybe the box of estrogen says you can only use this if you have hot flashes or night sweats. And we have to change that to sort of really understanding what gender affirming care is. We want people to feel like their best selves, and we want to help them do that through a biopsychosocial approach. And so you really do need to be inclusive. And so again, for Dr. Oluko and I, we see everybody. And that's really fun because we actually see how people are not that different. And we actually use a lot of what we know about one side of the genitals and actually use them to help us with the other side, right? And that becomes really helpful. But when you only teach gynecologists gynecology and you only teach urologists male sexual health, like no one's talking to each other. And that's a big problem. We actually want couples of any kind to talk to each other in the bedroom and to know, oh, this is, you know, I love when couples come watch me do an exam and they're like, oh, that's where that is? Oh, it hurts there? Wow, I thought I was just unattractive now. No, like it's like a sunburn on the, you know, on the parts. You know, it becomes, biology actually helps to make this less scary and less emotional and less about feelings and more about physiology.
Hey, education is really important from you, from me. Here's one thing that a lot of women always feel uncomfortable about. Women will come in, they'll say, let's say husband tells me there's something wrong with me because I can't reach orgasm with his wonderful thrusting. And so first I have to sit her down and explain delusion disorder. Thank you to the psychiatrist. And then we have to explain that the majority of women, females, people with a clitoris are not reliably orgasmic with penetration alone. And they feel like, oh my, really? I'm not broken? And that is so empowering to women to say, you need to figure out what works for you, which is why getting a vibrator that penetrates may be nice for some women who are lucky enough to have that sensation and can reach orgasm with penetration. But they need to, if you don't, you need to find more external vibration, which is usually going to be the most effective, especially as we age, based on the nerves.
You know, I want to circle back a little bit because we talked about SSRIs and libido. but it's also the issue with having orgasm issues on an SSRI is very, very common. And in what, about 30% of people you would say it does go away on its own. But what someone wants to throw out your solution for the patient who is an SSRI who cannot have an orgasm, beyond all the things that you already talked about in terms of decreasing the dose and all of that?
I think it is all the things we talked about, right? And you have to tinker and get it right for you. This is where it becomes customized care, and toolboxes are really important, and it's important language, because your orgasm really matters. It's really important. But you may go to your general provider and they don't really have the tools to help you, or the time they're like, lady, I got people with cancer, people having babies now. Like, I don't have time to tinker with your orgasm. But there are providers out there that's what we care about, right? Like, it matters. And if it matters to you, it should matter to your clinician. And so the key is we have to get it right for you. So depending on your mental health history, depending on what medicines you've tried, depending on what's going to work and what you're open to trying. So it may be a device. It may be Viagra or Cialis. It may be changing around your SSRI. It may be adding something like Addy or Vyleesi on top of your SSRI.
But wouldn't you agree, though, that we talked about, that Viagra is not always going to work? But if it does work, isn't the woman, I think, and I want to know if you agree, that it's most likely to work and is the woman who loses her orgasm specifically because of an SSRI?
Well, we do have some data to show that Viagra can work very well in women with SSRI-induced sexual dysfunction. And the answer is, we've got great data to show Cialis helps prevent heart disease and heart attacks in men and all of these things. So I think it should be in the water, to be honest. But, but I think it's understanding how again, it's really erectile dysfunction, right? Orgasmic dysfunction is erectile dysfunction in women often. And so things like Viagra and Cialis and devices can work quite well, just like they can for my male patients.
So we are working on a topical Viagra, sildenafil is the generic, for women with arousal disorders, because now, we always have to use male products because there's nothing FDA approved. There are only two drugs approved for HSDD. No, it's
off-label. And compounding pharmacies will do it.
Right, but we are looking at, and phase 2 trial just completed, we're waiting for the data for a topical sildenafil for women with arousal disorder. And again, we have nothing for orgasmic disorder, nothing FDA approved.
Or just on the clitoris? Because
both.
Okay, because vaginally I could be convinced, but because like rubbing
Viagra
Viagra
anything
on
the
the
clitoris
penis
long
doesn't
enough,
really
it's
work
gonna
very
help.
well. Like we would have if it actually worked, we would have a male product already.
Okay, you guys are going to be so
I could get
happy
into the wonky science.
because now we are going to move on to the bladder, your favorite organ, right? Yes. Okay, but before we move on, I want to point out that there is Menopause Talk number 3. You will get a full hour of these two experts talking about solutions for recurrent urinary tract infections, urgency, frequency, leaking, a full hour, and really you do the deep dive. We don't have that kind of time now, so I encourage you, but just give a little bit of an overview of quickly, because it's really what we've been talking about, how this is going to affect the bladder. What are we going to? Yeah, I know.
Okay, so a healthy vulva is a healthy bladder, period. That's it. If you do not have a healthy vulva, you cannot have a healthy bladder. So if we look at that diagram here, you can literally see that the opening of the bladder literally sits within the structure called the vestibule. That structure is dependent on hormones. It's all the same tissue. And so again, I'm thinking about optimizing your tissue health. If you do not have a healthy vulva, which includes all of the things, which typically is with hormones, you cannot have a healthy bladder. And so oftentimes there are so many people coming into my office saying they have recurrent UTIs, they have, whether it's true, whether it's not. Because actually I looked at my data, 60% of premenopausal women come into my clinic with recurrent UTIs. It's actually the vulvar condition. It's not the urinary tract. And so there's a lot of misdiagnosis of urinary symptoms that are actually vulvar symptoms. And if your vulva is not healthy, you will constantly think that you have a UTI, whether it's clinically true or you feel the symptoms. That's also a really interesting thing of people come to my office and they're like, I swear, and like they're like trying to convince me. I'm like, I believe you. It's not they're like, I have a negative culture. I have this, but I have symptoms. And I always tell them, I believe you. It's not your bladder, it's your vulva. And we do obviously they do the full workup as a urologist, but what I've been finding is that if you do not have a healthy vulva, you cannot have a healthy bladder.
Dr. Rubin, keep it short. 2 sentences.
We just don't teach this to urologists, which is the problem, which is we go, like literally Dr. Luco and I are going door to door to urology programs lecturing for free because we're trying to teach the residents that this is really important. And no one taught us in medical school how to examine a vulva. Nobody. Nobody taught us in urology school how to examine a vulva. So we are literally going door to door to say, here's how to do the exam. Here's why it's important. And so again, this is not just about sex. This is about like health, because that, you know, little old lady in the nursing home is dying of a urinary tract infection, which we could prevent if we were using local vaginal hormones. So just really important that urinary health, like menopause and urinary health go together hand in hand, and we got to start talking about it.
And let's just talk for a second about the fact that below the waist has become a no-fly zone in the internist's office, and that they're not even looking at your vulva because they say you don't need a PAP. Well, PAP has nothing to do. Have we even mentioned the word PAP test today?
Nope.
No. A PAP has nothing to do with any of this. So, Dr. Loco, talk about, should women from over the age of 50 till death have a vulvar and a vaginal exam?
Yes, 100% yes. So we use the term vaginal atrophy, and we just toss it around in the medical field. And it's essentially like, if we actually think about it, we are permitting a whole organ to become unhealthy. It's just like if they told me if I didn't walk, this leg will shrivel up. It's like, well, you could just walk 10 minutes a day and this leg will stay healthy. We could easily be preventing so much suffering, pain, all of these things if we prioritized vulvar health. In our primary care providing clinics, in our gynecology clinics, in our urology clinics, it should be the exact same. I strongly believe that, you know, just like you get a mammogram, just like you get your heart checked, just like you get this, you should be getting your vulva checked, and you should be making sure that your vulvar health is optimized, because without all of those things comes this, like, the sequela, the long list of all of the downstream effects. And also, everyone, look at your vulvas. Go home today and look at your vulvas. So there is such a fascinating thing of every time I examine a patient with a vulva versus my penile patient, they apologize to me, every single one. And I thought that was the strangest thing initially, but now I'm realizing it's internalized shame that we've all been ashamed to look at ourselves. And when you're not looking at yourselves, all of these changes start happening, and you never know. And so I have people come to my office, they look at themselves for the first time, and when the symptoms start happening, and I'm like, this is like decades of changes. The symptoms just started now, but this is decades of changes, and we could have prevented this if you knew this. And so that's why I always encourage people to look at yourselves, and frequently, you know, just like we talk to do testicular exams, look at your vulva every month. And once you start noticing these changes, go see someone.
Yeah, we need to normalize the vulva.
Yeah.
And look at my Instagram at Dr. Strike to see the Great Wall of Vulva. 500 vulvas, that's a whole nother story, but I won't go there now. But okay, so if you think it's hard to find someone who's gonna help you with your hot flashes, try finding someone who's gonna help you have an orgasm, right?
Okay, switch.
So, Dr. Kingsburg,
Give a plug.
please talk about
Yes,
how you find
absolutely.
such a person.
Well, now you can, besides going to NAMS, now you can go to the International Society for the Study of Women's Sexual Health, ISSWSH, ISSWSH.org, and you can find a provider there as well. They are not specified by, you know, whether they're a gynecologist, psychologist, but you can then look at their profile and find somebody there. And that's a nice one. ASECT, AASECT.org, all sex therapists, varying interests and qualifications, but ASECT has also sex therapists, and STAR, it's the Society for Sex Therapy and Research, SSTAR.net. STAR.
We're going to take some of these resources and email it to everyone who attended today. Okay? I won't guarantee it's going to be this week.
I'm disconnected.
Next week? We got
Okay,
we'll
we're
get
gonna
that.
open it up for questions
Yes,
now?
we're going to open it
And
up for
my
questions.
iPad seems to be disconnected from the internet, so I'm not seeing them.
Okay, so Jessica's
are you
Jessica's
gonna
going to
put them up
take
on
out
the
that
screen?
poll. She's going to stop the poll and then put up the questions. And does anyone want to come up here and ask a question?
But we'll take a question in the back, and the woman in the dark, yes.
Oh, we go here.
Oh,
Sorry.
all right. Hi, thanks very much, first of all. I only recently discovered where my bladder was because it has never been an issue. All of a sudden, things are feeling wonky. And I didn't know what specialist. So I went to all my usual ones, the GP, the OBGYN and all that stuff. And then I said, well, I probably need a urologist, but a urologist is a male problem doctor, right? And I guess my question is this do you need to introduce a urologist as a matter of course when you hit menopause? And the second question is, you are the first 2 female urologists I've seen. Yay.
Did you hear the question?
Is it a heavily male-dominated profession?
Yes. So we are less than about 10% of practicing urologists. If you want to meet a cool person, obviously, women urologists are cool people. We have to be funny because we're penis doctors, right? We have to be funny. And so we all get along very well, but we're about 10% of practicing urologists are female, but the residency training is 25%. So we are growing in number and getting very, very loud. And so when we get board certified, we are board certified to take care of all genders. We are just get worse training in taking care of women. And so we are actively trying to change that. We do. And the American Urologic Association is incredibly supportive. We have courses, we have trainings, we have core curriculum. And so to your question is, you have to see a doctor who or a provider, clinician, whatever you want to call it, who knows about this stuff. And so there are lots of gynecologists who do urologic stuff. They're called urogynecologists. There are a lot of female urologists who focus on female issues. There's a lot of men urologists who do female urology specifically, so it gets confusing. So the key is getting good referrals, finding someone who cares. And those websites, ISWISH is very helpful to find a clinician who is going to do those things. I hope that's helpful. But we're changing, we're growing. And I wish to one day, right, that all women's health is not just gynecology. It's enough already, right? This is misogynistic that there is one medical field for all of women's conditions, primary care, cardiology, urology, like we all take care of women and we all just need to do a better job. And that's why we're yelling and screaming in the work that we're doing.
The question, is GSM inevitable? The answer is it's about 70% of women will get GSM. And it is something that can present later, and it will not get better without treatment. But I do want to get to this question, which is so good, about, where was it? About how you put estrogen on. Should the cream only be used around the urethra or in the vagina? Because you talked so much about using estrogen cream, but you didn't really say, where do you put it? How? Be specific.
Yeah. So this is where, again, knowing your anatomy is really important. So I actually, in my clinic, I will examine the patient. There will be either my colposcope, which is like they can actually see themselves on the screen, or there's a mirror depending on where I am. And I actually make them put the medication on their finger and then show me where they're going to put it. Because if you, again, gardening, I don't know why I don't garden, but if you have your gardens over there and you're watering over here, like, of course, you're not going to get any cucumbers or whatever you're growing, right? And so you have to also know where you're putting it. And you want to put it, depending on what you're using, whether it's, you want to put it inside the vagina and the vestibule and coat the vestibule as well. And so.
Can you define vestibule? Because not everybody knows.
Oh, yes. So do we have that picture? So the vestibule it literally means entrance to the temple. And so.
Entry to the temple.
We think about the vagina as the holy temple. The vestibule is all that tissue surrounding it. It's actually a really, really important structure. And it's bladder tissue. It is essentially bladder tissue.
And it doesn't matter how nice the room is if you can't get through the door. I'm just saying.
Exactly. And so it is, you want to essentially spread apart your labia minora and get the medication into the vagina and all around the vestibule, because it's really important.
Properly dosed, because a lot of doctors will tell you just use a little.
Yes, you do not.
Dab on the urethra. You can dab it all over your urethra, but you need enough. So you need at least 1 gram of the cream. And I like the tablet inserts often to start off with, just because then the ER doctor can prescribe a tablet insert. But if the ER doctor is talking about cream and doses, and women don't often love putting creams in their vagina, so the best therapy is the one that you will use and you will use forever, whether it's a tablet insert or a cream, and you have to use enough so that it helps your symptoms, and it takes 2 to 3 months to work. Okay, you don't get a plant back from being too dried out overnight. You gotta, right? Garden. I love that analogy. You have to give it time, right?
I just wanted to ask a quick follow-up to, I don't know who asked the question, but if you go to see, are all urologists male? trained to deal with women? Or do you have to find a female urologist? That's my question.
Fellowship. These are fellowship
so-
trained.
so
This is
we-
sexual medicine.
We are a little bit unicorn in the fact that we did a fellowship training in sexual medicine for all genders. So we take care of all genders for sexual health problems. There is one fellowship in the entire country that acknowledges women's sexual health. One. And it does everybody, right? Men and we both did the same fellowship. That's why we love each other very much. And when we talk so fast, is because we know you are only going to be in our presence briefly unless you follow us on social media, because often you don't get this kind of information. And so we talk really fast because we want to teach you everything we know as quickly as possible. And so our male colleagues and our female colleagues, they learn from us. They come to our lectures if they're interested. But many are not interested in this. And we have to beg. But that's why we have to be funny, because we have to convince people to be interested in this, because it is not, but we do have a core curriculum within urology, which has female sexual medicine topics, and that we know because we wrote the damn thing. And so, but gynecologists do not have the same core curriculum. They do not have places, urologists do actually. So that's actually, again, in the fact that we think our gynecologist is supposed to know everything. It's not fair. They can't know everything about everything, and we should stop expecting them to.
And I think this is also where I like to light a match underneath people. It's that, you know, this is where politics and policy comes into play. So we've been up on the stage saying the beauties of sexual health and how great it is. And then you're going to walk out and realize, holy shit, I can't get anyone. I apologize for swearing. I swear a lot. And so that is the issue. So we look at the research and education. So we look at education. We did not learn how to examine a vulva until we were in fellowship. Like the urethra is right there. We're doing these crazy vulvar vaginal surgeries, and yet we never learned how to examine a vulva. And then if we look at gynecology's training, if we look at primary care training, ER training, like all of these people that are interfacing with the vagina, you are not getting that training in your medical education, which is terrifying. So there's a whole workforce of people that have no idea how to examine, you know, we get taught how to, exactly.
Women's sexual health will never be important enough, right? There's like heart disease, and there's, you know, babies, and there's like cancer, and all of these things are always going to be more important than your orgasm. But that's why we yell, because your orgasm really matters,
And
right?
fast.
What? And we talk.
And talk really, yeah. But also,
I want to keep running through
Sorry,
questions,
yeah.
because I really want to try and get
we
people's
could-
questions.
Sorry.
So I think this one is a really interesting one, talking about, you know, physiologically, why does the changes GSM affect the bladder? And I did talk a little bit about estrogen receptors in the bladder, but I would like someone to address the microbiome and why vulvar washes are idiotic.
Well, so again, and Dr. Stryker did a great job, but it is not just estrogen receptors. There are testosterone receptors in the bladder as well. And so when you play with hormones, there are consequences, sometimes good and sometimes bad. And so different hormones that you bring or lose from your body are going to affect every part of your body. So your skin, hair, and nails are going to change in menopause. Your bladder is going to change. Your muscles that surround your bladder and the muscles of your bladder, because your bladder is just a muscle. Your clitoris is just a muscle, and it needs hormones in order to be healthy. Think, you know, The Rock, right? He's got big muscles because he's got a lot of testosterone. And so hormones are important for muscle health. And so when you don't have them, they get thinner and raw and cracked and irritated, and muscles do not like to be unhealthy. So they get really urgency, right? Your muscle squeezes. You feel, oh my God, I gotta pee. You get frequency. You get urinary tract infections because the microbiome has now changed. Without vaginal hormones, you lose the acidity to fight infection. So you do no longer have an acidic area to fight infection, so your microbiome gets all wonky, so you start getting urinary tract infections and vaginal infections, and hormones can prevent those things, and we're into prevention. We don't want to see you when things are miserable and you're 80 and you've been having infections, you know, every month. It doesn't have to be that bad, and it shouldn't be that bad with good education and safe FDA-approved treatments that can actually fix the problem and not just be a little lubricant or moisturizer to put a barrier on it.
How does oral sex get impacted with all these topical products? What's the order? What goes first? Great question.
All right. Yeah. You just put it on afterwards. High five and then put it on afterwards.
words, really rub it in. But the other answer is men have estrogen and testosterone, right?
They're not going to grow breasts.
Men have an estrogen of 25. You're not going to even blip their estrogen if they touch your vaginal estrogen product. They need estrogen for their bones, for their libidos, for their brains, their skin, hair, and nails too, right? It really needs hormones. So men have estrogen and they have about 10 times more testosterone than the average reproductive woman. So it's, again, numbers matter here because it's very fearful of, I don't want to hurt my partner. And so we talk a lot about numbers with patients because it makes them feel, makes them feel better. So if a man's tongue touches your vaginal estrogen product, it will not hurt him.
And I think also important to mention with the lubricants, of these flavored lubricants, we talked about osmolality. Oh my God, it is poison in the vagina. Do not put these flavored lubricants in your vagina. We're talking osmolalities of 10,000, 15,000. Your vagina osmolalities 300. So that is not the answer. Just osmolality. This is the concentration in the vagina. So this is why so many of the water-based lubricants actually make your vagina drier. They destroy the tissue. And everyone always says, how are we going to know the osmolality? Well, I do have charts and lists in my books and your websites, and you probably do too. But the easy way is, if it doesn't say it on the bottle, I guarantee you it's really high. Like, if it's low, they're going to advertise that. If it's
So the
high,
higher means that
high
you're
is
going to get that, like worse dryness.
right. You
higher
want it to
the
be
osmolality,
ideally 300-400 max.
We're getting a bunch of questions on laser technologies to the vulva and the vagina. And let's talk about it for a second. There is evidence, some evidence, weak evidence that okay, we can fight about it. There is evidence that if you use a laser on the vagina, you can resurface the tissue, just like in the face. We took it from the dermatology. You can get all these face lasers and things like that. So if you do it to the vulva and the vagina, there's some evidence that you can kind of regenerate tissue, beef it up, make it a little stronger and healthier. And they may be effective for some people, but they're not covered by insurance. They're very expensive. And if your doctor is recommending a laser-based therapy only and not a vaginal hormone product, then it's against everything that we believe in, because the foundation has to be strong. And there is no reason not to use vaginal hormones. Remember, there's no person where it is a true contraindication or not allowed to use hormone, like local hormone therapy. So you can use, if you got all the money in the world and you want to try a cool laser and you don't have a reason, right? But everything can have side effects. So this woman here in the question, right? She developed pelvic floor dysfunction and vaginismus.
She had it in the first place. I have to disagree with you here because we had a little, okay, there is excellent evidence that laser does work in terms of changing tissue, but it has to be in the right candidate, and it also has to be offered in conjunction with everything we've already talked about. But I don't care if we are giving someone estrogen, DHEA, testosterone, whatever, you must treat the pelvic floor as well, because those are the failures. So too often when women come in and they say, I had laser and it didn't work because that wasn't their problem. Their problem was tight pelvic floor muscles. You need an exam by someone who knows what they're doing. And I agree, everyone is a candidate for vaginal estrogen, but unfortunately only 6 to 7% of women are using it. Women with breast cancer are terrified to be in the room with the molecule of estrogen, and we have to offer something.
Again, and it would probably...
Wait, you need RCT, randomized controlled trials.
We do have them.
We
There
need
are
larger ones.
They're not huge. So we need more data. We need more data.
Okay, so I'm
That
gonna
means more
get
data.
here
We're gonna get
and I
kicked
got
off.
my microphone on.
Yay to
get my microphone
Donna.
on. So listen, so we have to end, and I am so sorry. And the reason why we started Let's Talk Menopause was to get you guys in front of these guys, right? And we love that there's some disagreements. Of course, there's going to be some disagreements on what to do, right? Of course there are. But we want to present that to you. And I want to ask, who here is mad?
Every day, all day.
Mad?
Just angry.
Now we're giving the Jen Gunter award.
Let's